Welcome back, listeners, to the Invisible podcast. My name is Dr. Ashton Wilson. I am your host, and I am here every week talking to amazing guests. And this week, we are not short of amazing in here. We have got the fabulous director of Ocean Kids, Katie Cleary, with us today. Hello, Katie.
Hey, Ashton. Hey, go.
Yeah, really good, really good. It's so great to have you here. We were just having a brief chat before the call about how we connected about just over a year ago now. And I've been admiring your journey with Ocean Kids from afar. You are in the southeastern suburbs. I'm over here on the west. But I absolutely love what you're doing down there at Ocean Kids. But before we dive into that, how's your week been? What have you been up to?
Just been a busy week running around after my little one. So I've got a 15-month-old bub at home. So doing all the fun mum things. We're at Acro Kids this morning, and yeah, just doing a lot of work stuff as well. Also, I'm in the clinic a few days a week, seeing lots of little people with hypermobility and other conditions. So yeah, kind of juggling mum life and work life. But yeah, it's going really well.
Yeah. It's one of those things, the old saying of like the work-life balance. I feel like once you throw kids into that, it's like a juggling act. It's not a balance.
Yeah. It's just a life balance, just trying to give everything a little bit of time and be present and enjoying it as well. Yeah.
Yeah, fantastic. So, yeah, I mean, we are kind of heading towards the end of winter now here in Melbourne, so it's starting to become a little bit more enjoyable. Do you spend a bit of time down at the beach in Seaford?
Well, not so much Seaford. I'm very very into my surfing, so we're loving sort of the winter swells down the peninsula down here. So we've got nice thick wetties, and yeah, we try and surf as much as we can in and around all the baby stuff. But yeah, Seaford's beautiful too. There's lovely beaches there too. But that's where our name Ocean Kids originated from, because we were lovers of the water and we did a lot of sort of water therapy with kiddos, and yeah, then sort of Ocean Kids stem from there.
Yeah, so beautiful. So, yeah, you are the director of Ocean Kids and you're a pediatric physio, am I correct?
Yeah. Pediatric physio. And so Ocean Kids, we've got 2 clinics in Seaford, and we sort of work with kiddos sort of all around the southeastern region, some kiddos from the city as well. We do a lot of telehealth with families sort of from all over Australia and some overseas as well, just for that sort of support with kids with connective tissue disorders in particular. So yeah, it's awesome.
Yeah, and this is a fantastic segue into, I guess, diving a little deeper into what makes Ocean Kids so special. And I think it is the work that you do with the hypermobile population for little ones. So tell me a little bit about what inspired you to go down this pathway to working with kids with hypermobility.
Yeah, well, it's sort of, I think from listening to some of the other amazing guests that you've had on your podcast, Ashton, there's often a lot of lived experience from, I guess, getting into this space. So I was always going to, I guess, be a physio, and I was keen to work with like footy players or surfers. I was really into my sport. And then when I was at uni, I started working with a little girl with an acquired brain injury, like as a carer. And I had sort of no interest in, well, didn't realize I had an interest in working with kids. And yeah, that just really sort of sparked my passion for helping little people, because it was just so meaningful. And I guess the difference that you could make with a little person, and a lot of kids just recover really quickly, or they have a lot of sort of fast progress. That was really cool to work with as well. So I had absolutely no idea what hypermobility was until I was about 25, and I was over in Perth, and I was doing a DMI clinical Pilates training course, and the instructor of the course did some tests on me, and I had sort of, they called it like an autonomic reaction to some of the testing, and I was very, what they called, hypermobile. And until then, I had absolutely no idea what that was. And so that was sort of having sort of not formally diagnosed, but sort of chronic fatigue symptoms as a teen, had sort of lots of issues with pain through my sport and that kind of thing. So I kind of got an informal diagnosis at the age of 25. And then I was just really fascinated. I was kind of like a sort of a dog with a bone, and wanted to know a lot more about it. And then that just sort of sparked my interest. So I kind of started doing my own research, then, going to the Ehlers-Danlos conferences and linking in with other people. And then it's just kind of evolved over a long period of time. So probably at least sort of 15 years I've been working like in the pediatric space with kids with hypermobility. And I guess yeah, just the networks and people that I've met along the journey has just been amazing. So I've got a formal diagnosis of HSD myself. So I guess having a lot of that sort of teen experience with dysautonomia and fatigue and pain and things like that. But I think my real passion is just I want to help families be validated and get recognised earlier. So that's where a lot of my work at Ocean Kids Health, aligns with those families that. And often, they're families that have seen lots of different practitioners, and they're sort of coming to you a little bit later, and yeah, just really wanting answers for why their kiddo might have chronic pain, or why they're not keeping up with their peers, or why they're having so many tummy issues and migraines, and those sorts of things. So I love helping families to get that diagnosis and recognition, because then the earlier, and I guess sooner we know what's going on, the more support we can give kiddos to have a much better quality of life as they're going along. So that was a long-winded answer, but yeah.
Well, I think that, you're right in saying so many people who work in this space, they share in that lived experience. And I think that that's what makes, what you do, because you found out at like 25, you said that you presented with joint hypermobility. And then I find it really fascinating that your interest has really kind of divulged mostly towards the kids and the little people. And I think that's such a special place to work. I think it takes such a special person to work in that space. So first of all, I absolutely admire what you do with the little ones. And I know, just as a tangent here, the first time I saw Katie was presenting at the Ehlers-Danlos Society conference in Brisbane, and you presented, and the way that you spoke, it was like you were an advocate for these little people. And I loved it so much that I remember your talk so much, because it really resonated with me, is this idea of, almost like advocating for the kids and the parents and just validating their experience. And you've just described all of that there. And I think it's really clear to see your passion alongside your inspiration as to what got you into this pathway of working with little kids who are presenting as hypermobile. So yeah, it's really, really just shining through in the way that you speak about it. I guess then tell us a little bit more about your work with pediatric hypermobility, how it presents to you, and what you and your team kind of do about it, because I'm aware that it's a different approach, but I'd really love to hear from you, from the horse's mouth, what is going on inside the walls of Ocean Kids.
Well, so we get a lot of referrals from families, here, there, and everywhere, where they're obviously concerned about their little person. So sometimes we'll get referrals for kiddos, and they might be looking to get a diagnosis of hypermobility, and they might be in that early intervention, sort of that 2 to 5 year old range. And so, I would just sort of love to talk about sort of what we recognize at that age, and then talking about sort of that, I guess, the lifespan of hypermobility. So hypermobility, it's extremely common in kids. So in girls, about 25% of girls have hypermobility, and at least 11% of boys, and there's probably a lot more than that. So, and hypermobility is extremely common. So kids have very different joints, that are immature, and so as they develop, things get, more congruent and stiffer and tighter, and as everything sort of forms nicely together. So hypermobility is a normal finding in kiddos. Where it can be a more of a problem is when there's hypermobility plus symptoms. And so often in little kids, we see those symptoms being maybe difficulties keeping up with their peers, potentially motor delays. So they might have a little bit of difficulty with some of those early milestones. You'll often notice sort of some abnormal postures, or they might tend to W-sit a little bit more, or their knees might knock together, or they might have feet that turn in. And these, these findings can be as a result of a range of other conditions as well. But there's these patterns that we see with little people with hypermobility. So, and the kiddos that are having, like those early kind of tummy problems, they're starting to have pain, and they're having difficulty. They're the kiddos that want to be carried a lot, have a lot of difficulty sort of walking long distances, and we know that children with hypermobility, particularly in those preschoolers, will often have sensory processing difficulties as well. And that's due to their body awareness and those differences because of their floppy joints. And so when we're looking at the kids with hypermobility when they're quite little, often they'll be referred to us potentially like from an occupational therapist or a GP, as the child will have low muscle tone. So we'll be sort of accepting a low muscle tone referral. And we always screen for hypermobility in our little ones that have a diagnosis of low muscle tone, because those two conditions very commonly run hand in hand together. We don't know why one of them may cause the other, but there's definitely a relationship between those two conditions in little ones. So when we're looking at sort of the hypermobility, we're really assessing the little one's joints, and we're looking for laxity in those sort of the toddlers and the preschoolers. And so it's sort of a specific diagnosis of hypermobility, we're not looking at giving kiddos until they're 5. And the reason for this is they don't have enough bony maturation for the testing to be accurate. So we're kind of screening kiddos, and we're sort of say at risk of hypermobility, or we'll say they have increased laxity in their joints, which just means we know that they're going to be hypermobile, and we know that they're floppy and flexible. And so it doesn't affect anything in terms of how we would treat the child, but we're looking sort of when they're a little bit older for that, the formal diagnosis. And then at the age of 5, we're using our international pediatric diagnostic tool that we created with the Pediatric working group with the EDS Society. So that was released in 2023. So that's a diagnostic tool for kids that are 5 and over with hypermobility. And so then the fun bit is the treatment. So we're wanting to provide obviously a lot of education and validation and support to families. But then essentially we're just really wanting to help kids achieve their goals, but with the foundation of normal movement patterns and strength. So we're really wanting to help kiddos to get strong little bodies in those anti-gravity positions. So, when they're upright, when they're walking, when they're crawling, when they're running, we want them to be strong. We want them to be confident. And so we're targeting all of our interventions to address that. So we do a lot of exercises in the pool, and we do a lot of body weight sort of strength exercises, but it's all really fun and really play-based, because otherwise it's boring and kids don't want a bar of it. So, but yeah, and a lot of it is sort of exercises that families can do at home, but it's very much exercise-based and education-based.
And I guess that's, I mean, what you're describing there is such a holistic way of working with a little one. And I guess when we work with, adults, it's very easy to work with an adult who has a goal, right? And I work with mostly adults, and it's interesting because I'm seeing quite a lot of, 10 plus are coming through my clinic. And I guess there are a lot of parents who are finding my content and are going, hey, maybe I need to see you, which is great. But I find the real difference with an adult who understands what they want to achieve versus a younger person, whether they be a child or a teenager, who, they just want to hang out with their friends. They just want to be able to sit at school and, do the things kids want to do. It's a very, very different approach. And I think it's really interesting how you say there that, the fun part is the treatment, is the getting them strong and getting them, moving and doing all these things. Are there any, techniques or approaches that you use in particular that is very different to how you would deal with an adult population?
Yeah, it's completely different. So I used to work with adults with sort of chronic pain a long time ago when I was sort of early career. But it's really different. So we're looking at the kiddo and how they fit into their family and their family unit as a whole. So we're addressing what's important to the parent, the siblings, the family. So it might be the parents might be really into their bike riding, and their little one can't ride a bike, or isn't able to keep up with the siblings. So and then looking at addressing that goal within the scope of whether that's important to the child as well, and whether that's a realistic goal. And then we're always looking at sort of breaking down the goal and looking at the components. So kind of working backwards in terms of what the little one might be struggling with. So is it balancing on one foot to be able to step over the bike? Is it being able to steer? Do they have a coordination difficulty? Do they have a motor planning difficulty? So it's kind of breaking down what the components are and then practicing those things in a fun way. So we use a lot of different games, balloons, different footballs, lots of different sort of obstacle courses, laser tag, bubbles, any of that sort of really fun stuff. And it's always targeted. So if the kid's really into footy, we're absolutely going to be encouraging and supporting them to achieve any of those goals. Or it might be a little one really wants to get better at rock climbing. Fantastic. So we help them to kind of work out what the bits are in that skill that they need for rock climbing that they're having challenges with, and that's where we come in and we help them sort of fill in the gaps so that they're able to do what they want to do. So yeah, the goals are very different in kids, but they're awesome. So I think that was where I loved starting. So I did a lot of work a long time ago now, but with the DSA, the Disabled Surfers Association down the peninsula. And I really wanted to help kids, have more enjoyment in the water, because that's been such a passion of mine, is my surfing. And yeah, so it's sort of, we're really wanting to support kids, to do anything that is meaningful and important to them, because, we're always, and you're probably the same, Ash, just movement is medicine for all of our little people. So it doesn't matter how you move and what movement you want to do, but that's what we're wanting to support them with.
My gosh, that sounds so fun. I was thinking then, maybe I should be bringing more obstacle courses to my grown-ups. Like, how fun does that sound? Oh.
We do this with that. I've got lots of teams that we see. We were doing like this Connect 4 Uno obstacle course with hoops and balloons, and yeah, it's just, and I think, and a lot of this is applicable to adults too. Like if you're finding joy and you're having fun in what you're doing, it doesn't feel difficult, and then your body can do more. So it's, I don't know, it's just, it's a lot of fun.
Agree more. I think we need to be having more fun in life. Like, exercise should be fun and movement should be fun. And, I find it so interesting all the time. People will ask me, well, what's the best movement for a hypermobile body? And I'll just say, well, what's a movement you enjoy? Let's do more of that. What do you actually like doing? There's no perfect fit for everyone. It's just finding joy in that. And I think that that's something that as we grow up, we forget that movement can be fun. It's not just about moving because you have to. There should be fun involved. I just love hearing that so much. Okay, on that point, what do you find is the most challenging part about working with our younger population, our little ones?
Challenging, probably in the sense of like the broader healthcare system in terms of recognition. So often we're looking to, when we're using the Pediatric Diagnostic criteria. So if you have a child that's 6 and we suspect that they've got a connective tissue disorder, they fill a certain amount of criteria to get one of 8 different types of hypermobility conditions in kids. Then sending that off to a medical professional that has availability to get that as a formal diagnosis is quite challenging. And the other thing that can be challenging, so that's sort of a bit more within the medical system, and it's early days in terms of the criteria. So there's still a lot of work that we need to do around education to GPs, paediatricians, rheumatologists across Melbourne, across Australia, internationally, just around this new criteria, because the criteria was designed to replace the 2017 adult HEADS criteria that we were using for a lot of kids, and that was the only way, apart from the Baton, that we were looking at a diagnosis of hypermobility. But then in terms of actually working with kids, it's time. So, everyone is, not everyone, so I'll rephrase that, but a lot of families that I work with are, that both parents are working because of the cost of living. There's multiple siblings, lots of families with children that are neurodivergent, lots of different needs, and everyone is just so bloody time poor. So trying to find the right exercise that's motivating, that's interesting enough for the child that they're going to want to do, that's not too taxing for mum or dad to have to build that into a part of their routine, to have to spend that much time doing this, so it's just really being really mindful of what else they've got going on in their world, and what's the most important thing that's going to give them the most bang for their buck in terms of improving their function or reducing pain, with being able to fit that into their really busy schedules. That's probably our biggest barrier.
Yeah, it is. It's interesting that you say it that way, because I think that, we are living in one of the most interesting times of history. And, we are I would say, generalized, most people are very time poor, and especially a family with, like you said, multiple kids. And then we factor in things like neurodivergence. There is a lot of needs. And I can see that being a big challenge to overcome for a lot of families. And I think that that's, like you said, making things a bit more bang for buck is kind of the way in, isn't it? You touched on there.
And fun.
And
just,
fun.
Just making it fun.
Yeah, making it fun.
And if we involve the siblings, and it's, it's something like the family, like we do a lot of family challenges. So, give them a challenge for the week, and they've got to do sort of like you get points for a competition and so then it's like a little bit of fitness for the rest of the family too. That tends to be a bit more fun and engaging for families.
Absolutely. I think that is a great way to get everyone active, right? You touched on a little bit there about neurodivergence And I think we couldn't have a conversation with you, our pediatric physio in the hypermobile space, without touching on neurodivergence. So just to elaborate a little bit more on I guess we know that there is a research-backed link between neurodivergence and an increased incidence of hypermobility. But what are you seeing in your clinic with presentations of neurodiversity, hypermobility, and how do you, I guess, approach that from a clinical perspective?
Yeah. It's interesting in the pediatric space, and I think NDIS has had a lot to do with the difference, I guess, in the landscape and, the recognition now of neurodivergence in our kiddos. So we'll often see a lot of kiddos that would already have a diagnosis of a neurodivergent, so, whether that be autism or ADHD or DCD. So we'll often see the kiddos that have a diagnosis first, and then we'll be doing the Baton and further testing and all, the assessments, and like, you realize you're hypermobile as well, and a lot of, so it's often sort of backwards from the adults that, so a lot of adults might be diagnosed with the hypermobility first and then, realize that there's some other things that might be contributing to some of the challenges that they're having. So, there's a huge correlation between autism, ADHD, and neurodivergence in kiddos. We don't have specific stats. There's a lot of research happening in that space, which is fantastic and super exciting. But it's just really cool because I think a lot of originally, there was that sort of cohort of kids in every Australian classroom that they're the naughty kids. They're the kids that bounce off the walls, that, they can't sit still, that kind of thing. But if you actually look at the child as a whole, yes, there's potentially some, they have the neurodivergence, but also they're hypermobile. They're not getting enough pressure from their joints. They're sensory seeking, so they're seeking pressure from their environment. So if you actually kind of, I guess, understand neurodivergence, but also what their needs are associated with their hypermobility, and really looking at their sensory needs, you can really impact their learning and participation in the classroom, because you can set them up with all of the tools and strategies and movement breaks that they need, to be able to succeed. So yeah, we see a really big correlation between hypermobility and neurodivergence. So, but, and not in every child, but there's definitely a link. And so I think it's really important, if you are a clinician and you're working with kids, if you have a child that you're assessing that has developmental coordination disorder, autism or ADHD, that you should always be doing a Baton screening and looking for some of those other symptoms as well, because of that link that we know is there.
Yeah, so interesting how you say that about the naughty kids in class, right? I had this, as you were talking, I had this, right? So I was definitely not. I was a very, very quiet student.
Really?
Yeah, very, very quiet,
Okay.
very, very, very much focused on, I guess, more the people-pleasing side of things and pleasing my teacher, being the best student. But I remember distinctly there was one kid in my class in primary school who was, and everyone knew he had ADD, is what we knew it as at the time.
Yeah.
And he was the naughty kid. But the way you just described that, then I think that there would be a lot of people who grew up in like the 90s and 2000s who would be hearing that there and going, that the way you just described their sensory needs and that they're not getting that feedback from their body, I think that just, it makes so much sense now looking back on that time, that person was just, not really getting that environmental like feedback that they needed to be comfortable where they were. And I think that that's something that I have really enjoyed watching our change as a society towards neurodivergence and our understanding of it and how it's shifted, because I think it's so important. And I mean, coincidentally for us working in the hypermobile space, now there's all this research linking hypermobility to, our neurodivergence and our neurodivergent population. I think it's just, it really gives me hope that in the future we're going to have much better ways to help these people get what they need and feel that they are supported and that they're not the naughty kids. There's nothing naughty about them. They just need things a little bit different. They need to have different accommodations made for them.
Yeah, absolutely. Yeah. I think there's so much work to be done in that space, but the landscape's definitely changing and improving. But we are absolutely not designed to sit still in a classroom for long periods of time. So
Oh,
it's all of those, accommodations for meeting kids' sensory needs, not just in the hypermobile population, but across all kids. Everyone's got their own way of learning and way that their body needs to be supported to do that.
100%. Couldn't agree more. You've mentioned a few times now I guess the 2023 diagnostic criteria that you were part of, which I didn't know, which is amazing.
Yeah, well, so through the Ehlers-Danlos Society, there's various working groups. So they're groups of clinicians internationally that I guess collaborate and do different sort of tasks and projects and research. So I joined the group, I think in 2022 or 2021, and because I was just doing a lot of my own research sort of over COVID, and then after one of the conferences I wanted to join because there was just some absolutely amazing clinicians that I wanted to kind of learn more of. And so I volunteered and joined that group. So one of the projects that we worked on was creating a diagnostic tool for pediatric hypermobility, which was fantastic. So that was published in 2023 and released. So that's now being used all over the world. But we need to get it out more to more doctors, pediatricians, various groups. So just so that we can look at giving kids an accurate diagnosis. And then the hope of the diagnostic tool is that these various groups of the hypermobility diagnosis in kids can then be monitored, and we can do better research on what those subtypes are and then how they manifest and then what they might look like as the children hit sort of adolescence and beyond that. And so at the moment, we're working on a paper it's like a therapeutic guidelines piece. So that will have a little bit more impact on enabling clinicians to have an evidence-based model of how to actually manage pediatric hypermobility in kids. So that's in the works at the moment, which is great.
Gosh, do we need it? So just for the listeners who might be listening and thinking, oh, what is that and how is it different? How is it different to the 2017 HEDS diagnostic criteria? Like, what would be, if you were to pick out some of the main differences, what would you select?
So the differences are, well, the 2017 HEDS criteria is really looking at that specific HEDS subtype of people that meet enough criteria to get that diagnosis. A lot of the items on that checklist aren't relevant to kids because they haven't had enough life to have had particular injuries, various skin changes, that kind of thing. So a lot of it was kind of irrelevant, but we found we were using that to be looking at diagnosing kids with EDS or HEDS, as sort of teenagers. And so instead of that criteria, that's why this was created. So now there's subtypes of pediatric hypermobility. So there's symptomatic and there's asymptomatic subtypes. So there's a group of kids that will just have generalized joint hypermobility. There's a group of kids that will have that and skin difficulties, skin changes. And there's a group that will have musculoskeletal changes. And then there's another group of kids that will have more sort of chronic and central symptoms. So they're the kiddos that will have sort of tummy problems, bowel and bladder problems, anxiety, and so having these other sort of comorbidities. So it's quite different to the 2017 criteria because it's very specific to kids. So it's for kids from the age of 5 up until either their finished puberty or 18. So sort of use 18 as a cutoff, and then they would use an adult criteria.
Yeah. So that's so interesting. And I think that just even the diversity of the diagnosis, I guess, I think is really interesting. And I think that it's absolutely what you described there. Kids don't have the life experience that adults have. And I always say, when people present to me, they'll say, my kid has pain, but maybe, I don't know if it's real. And I'll always say to them, if a kid is coming to you saying to you that they're in pain, you need to take it very seriously because they have nothing to compare to.
Yeah, absolutely.
They don't have the life, the comparisons that we have. If they're experiencing something and it's a signal and their body's telling them that something's wrong, we need to take it really serious.
Yeah. Yeah. And if it is that it's not a physical need, it is something, it's another need that they're trying to seek.
Absolutely. Yeah, we need to be listening to kids. They're not
Yes.
It sounds so simple, but we need to listen to them. And yeah, I think that what you're saying there, I'm really excited to see how this new research comes out with the therapeutic guidelines. That'll be just brilliant for all of us clinicians. And yeah, getting the word out there to other pediatricians, other specialists, super important, because there's so much we can do for kids, and those early interventions can be so important for, quality of life and, reducing the risk of injury as they get older, all of these things. I think that's just such important work that you're doing.
Thank you. I feel it's very cool. I still sort of pinch myself that I get to work with such amazing kids and families every day. It's and we've got across our team, there's lots of other clinicians that are very passionate about hypermobility and working in this space as well. So it's just great to be in a team of, like-minded people that really understand the conditions as well.
It's the dream. Now, I have a few questions from my Instagram followers that I'd like to pose to you. And whenever I get guests on, I always put it out to my Instagram community and see, does anyone have a budding question that they would like me to ask the experts? So the questions I have for you today, the first one is, at what age does hypermobility present? And what are some early interventions?
Yeah, thank you. It's a great question. So hypermobility can be evident right from when Bubby's really little, but we wouldn't classify it or look at it as hypermobility. So at that time, so often we'd see a baby that might be really floppy, that might have poor head control. They would have may or may not have a diagnosis of low muscle tone, but that is very common in that early stage. But it's also really important to note that this, that sort of presentation can be from a range of other conditions as well. So we would never be diagnosing a baby with hypermobility. We'd just be monitoring their joints and how flexible they are. So some of the key joints that we're sort of looking at are if their hips are really, really flexible, if their shoulder girdles and elbows are really, really flexible. So we'll notice that when they start to push up on their tummies or when they start to crawl, we'll notice some unusual positions of their elbows and their hips. And particularly once kids start standing, so looking at how much range of movement they've got in their ankles. So often they'll be really flexible. Their ankles might roll in, their knees might knock together. So they're sort of some of the early signs, but again, they're just signs. They can be, related to a lot of other conditions. So they're things that we monitor. And then early intervention for that sort of a presentation, we're really wanting to achieve normal movement and really support the child's sensory motor development. So we're making sure that they're tolerant of lots of different handling of touch. We're making sure that the child is happy to move in different planes of movement, so addressing their vestibular function and making sure their joints are nice and strong and stable. So they might need, little special shoes and things like that. In some cases, if their ankles are rolling in a lot and they're not able to stand properly, but really, it really is dependent on the child. But once we've got the sensory systems are working well and they're able to sit and start to crawl and things like that, we're really trying to work on just their strength and then achieving those sort of normal motor milestones and then helping the child achieve, everything that we would expect them to achieve sort of from 0 to 5 in terms of their gross motor and fine motor skills.
Great answer. I have a little side question to that.
Sure.
From my own personal experience. Do you see... So I did a very, very, very long time ago, I did a primal movement course where I learned from a really amazing man who was from South Africa about more primal movements that humans do and how to retrain them. And he was talking about, this is kind of what sparked my interest in hypermobility. Now I think about it, all the way back when. He was talking about how hypermobile babies will typically skip the crawling phase and go from rolling to standing. And I thought, that's me. I never crawled as a baby. I just rolled around until one day I stood up and decided I was going to start walking. Is that something that you see in hypermobile kids, or is this guy just on my...
Look, it's not... To miss a certain developmental milestone when you're hypermobile is not a typical presentation. There are motor skills that are more challenging for little kiddos. So if you're really hypermobile in your spine and in your elbows as well, so we call that sort of laxity in the babies. So if they're really floppy in their elbows and more floppy in their spine, tummy time is going to be really hard and a lot harder to maintain those positions for longer periods of time. Generally, the reason that babies would skip crawling is it sort of often it's driven from a lack of tummy time or really not tolerating tummy time. That can be from a whole lot of reasons. So like tight necks, reflux, low muscle tone, sensory issues. So, there's lots of different reasons. So I'd say your colleague and like those primal motor patterns, not every child with hypermobility is going to have a motor delay. And I think it's really important to note that some of our best athletes are very hypermobile, and some of our top performing kids in, particularly in sports that their bodies are really fantastic at. So that's like, your all of your dance and your performance arts kiddos and gymnasts and swimmers and things, a lot of kids will be hypermobile and never have any issues at all and will never know that they were hypermobile. So, there is this group of kids that will be a lot more flexible, that might struggle more with rolling and particularly crawling. And crawling is one of the hardest milestones to achieve because it's that whole body coordination. It's a lot of strength. You've got to lift your head up against gravity. But yeah, I think there is a lot to be said for those sort of addressing those primitive reflexes and the early sensory motor functions as part of the whole picture of therapy, if that's sort of what one of the issues is.
Good to know. Yeah. I just decided, obviously, I'm just going to skip crawling because who's got time for that? I'm just going to go straight to standing. No, that's good to know. It's good to know. And there's obviously, of course, everything is relative and everything is going to be within reason of all sorts of other conditions that could impact why someone might or might not do a certain milestone. So yes, thank you for answering my side question. Back to Q&A from my audience. What is the difference between hypotonia and hypermobility?
Yeah, great question. This is one of my favorite questions because I think we often see such a correlation or like a co-occurrence of those two conditions together. So low muscle tone, the medical name for that is hypotonia. It's the same thing. So low muscle tone is your body's or your muscles' tension against gravity in response to the task. So for example, sometimes like if you go sit on the train, there might be that guy next to you that's like reading the paper and he can sit upright and read the paper for 45 minutes while you're on the train. And you're looking across and you're like, how is that guy still sitting up? Like, whereas me, I've moved seats 8 times. I've got my legs up on the wall. So that's a person that would have normal or above average muscle tone. So it's a passive tension that's in your muscles. So it's like their readiness for action. So it's how tense your muscles are. The hypermobility is directly impacting your joints and the connective tissue. So the hypermobility makes your joints more flexible, and so sustaining different postures can be challenging. So that the two can look very similar, but you can absolutely have low muscle tone and not be hypermobile. But it's probably a little bit more common if you're hypermobile than to have that low muscle tone. I've worked with lots of kiddos with low muscle tone that aren't hypermobile, but generally most of our kiddos that come through that are hypermobile will notice they'll have low muscle tone as well. Mm-hmm. But it's tricky though, because there's no test, there's no specific test, and there's no specific assessment tool for hypotonia. We use elements of other assessment tools for hypotonia, but there's not one specific test. So it's a clinical observation. So everyone has a little bit of a different way of looking at it.
Interesting. One of those things, maybe some new research for you, Katie, when you've got...
I would love to.
And final question from my audience is, my 10-year-old hypermobile son runs long distances, approximately 10 kilometers or more. Is this okay?
Yeah, another great question. In terms of activity for kids with hypermobility, if they're not having any issues in terms of if they're not having, joint pain, if they're not having recurrent injuries, if fatigue isn't a big issue for a child, there's absolutely no restrictions on what they can do. It's more identifying problems early. So if a child's having pain, if they're having fatigue, if it's affecting their participation, then we're wanting to really intervene early. But, in a 10-year-old that's a sporty, typically developing child, there's no reason that they shouldn't be able to do everything that they want to do. But it's just monitoring as well. So like if there was any concerns with your son, just with his foot posture, or his leg alignment or anything like that, or if he had complained of any pain, it would be good just to link him with someone who is hypermobility aware to have an assessment, because it can be good just to work on specific muscle areas of strength and potentially just look at foot posture and things like that, just to make sure he's really well set up if that's a goal of his and he's wanting to really progress his running. But in terms of activity, we're wanting to encourage kids to do as much activity and any sort of activity that they're happy with, but within understanding what is going on for their body and what symptoms they might have, and then modifying at that time.
Mm-hmm. I couldn't agree more. I think that we touched on it before, that an activity that you enjoy is going to be the best kind. And if this young fella is enjoying his running, then I think keep running. But I think if he is reporting pain, exactly like you said, then listen to him. If he's saying that something's not right, then we need to get it addressed ASAP and take it seriously. I think that, sometimes I think we really do minimize what kids go through. And I think that the way kids are growing up in a world these days is very different to the world that we grew up in. And if they're reporting that they're feeling certain things, we need to acknowledge it and take it seriously. So great answer. Great answer, Katie.
And just to add, just want to add just one more little thing to that. Just in general, kids with generalized joint hypermobility, so that's when they've got 6 or more joints affected, like those kids are going to need a little bit more rest and a little bit more recovery time. So just making sure we're not loading up our kids with multiple days back to back of activities, and just allowing them to have full body rest, so sufficient rest after school. And that's not sitting up at a desk doing homework. That's like chilling out in the beanbag, having that full body rest. And just keeping in an eye, or just in the back of your head, just if there's any autonomic nervous system symptoms. So sometimes we can see a little bit more of that coming up in that early puberty kiddos that might be doing a lot of training and that kind of thing. So just keeping an eye on like just dizziness, tummy pain, headaches, that kind of thing, and just making sure those things are addressed early.
Yeah, absolutely. Great points there. And especially as kids are heading into puberty earlier and earlier. So just keeping in mind that, once they hit the double digits, like starting to pay attention to more of these signs and symptoms that can change as they get older and as hormones start to kick in. Yeah. Well, this has been an absolute amazing chat, Katie. I could talk to you all day and pick your brain, but we are going to start to wrap it up. So what would be your 3 key takeaways from this chat for the listeners?
Probably my number one takeaway is listen to your kiddos. So, and I know kids talk at you a lot and it's hard to filter out all of the things that they're saying, but if they're coming to you and they're saying that there's a problem, and often, particularly for our kiddos that are neurodivergent, often they don't really understand because of their interoception where that problem might be. But addressing and supporting them early with intervention and with the right tools and support can stop things like a chronic pain condition or a chronic fatigue condition that would otherwise, have been able to be managed in that early stage. So just listening to your kids and getting the right support. Second is make it fun. It's so important. Like just play to your child's strengths. They don't have to keep up with all of the other kids that are all doing basketball. They might be really into skating. Awesome. Support them with that and go all in. The things that they love and they're getting joy out of are the things they're going to thrive at. And it's, physical activity, any physical activity is worth pursuing. And the third one is just getting the right people around you. So I think just if you are finding that your child's presenting, or complaining of pain and fatigue and things like that, just making sure you link in with, like a health professional that's hypermobility aware, and that you can just get the right tools and the right support as early as possible. It's not even so much important to have that diagnosis straight away, but it's just kind of like someone that knows what the actual problem is and then how to support you guys just to prevent conditions from becoming chronic.
Brilliant. What a well-rounded recap of what we just chatted about. I think that they're the most concise takeaways I think I've ever heard on this.
A fourth? Can I add a fourth?
I think because you were so concise, I will allow.
Just a fourth.
Yeah.
Just help your kids get strong. So if that is through just a really simple little core strength program at home, a pool, if your child is into swimming, really encourage that, because the pool is so beneficial for kids with hypermobility. Just trying to build that foundation of strength will really set them up into their sporting and managing symptoms in their teens.
Awesome. As a former swimmer, I will say, yes, absolutely. It'll help you get real strong. Amazing. Well, thank you, Katie, so much. But before I let you go, I've got a few more questions to ask you.
Okay.
I ask all of my guests these questions because I just want to know a little bit more about some drops of wisdom from you. So let's give it a go. What is one life hack that has changed your life?
it's not really a life hack. It's just it's something I heard on a podcast not that long ago, but because I'm also an ADHDer. And so I used to always try and be consistent with everything. So it was always about, okay, I've just got to do this consistently. And I just can't do anything consistently. But I've just sort of discovered the word continuing. So I'm using that word and I love it. So rather than being hard on myself and like, I've got to consistently do my yoga and consistently do all these things, I'm continuing to do my yoga and I'm continuing to do that if it's next week or the week after. Like I'm continuing on that journey, but it doesn't have to go in a straight line like a lot of people can. So I just like the word continuing to, to work on those things, particularly around like physical health for me.
That is a great little tidbit there of advice. That's awesome. Yes, continuing to do something. I love that. What is one bit of advice you'd like to give your younger self?
Probably just to back myself and just to know that, like, I guess your passion will just bring the right people to you. So it's kind of like I've known about this stuff with hypermobility for a really long time, and I just sort of felt like I was kind of like out there on my own. This is pre-social media, and trying to share my message and just sort of like, am I getting this right? Do I know what I'm talking about? But I just looking back now, I'd be like, yeah, I did know it because I was experiencing it all myself, but just to back myself, but also, yeah, just know that the right people will come into my life as I'm going along because my passion's there, and yeah, and it's just, I just want to help people. So yeah.
Love that. And what is one thing you'd like to see change in the healthcare industry?
I think just a little bit more awareness around connective tissue disorders in kids, because a lot of the time kids can be misdiagnosed or not listened to, and there's a lot of the gaslighting and that kind of thing. But I think just for there to be more awareness about hypermobility in our healthcare system, and that there was more recognition, and just for the kids to be linked in with the right supports earlier. So I think there's still that diagnostic journey for adults. It's still very much applicable for kids. I'm still seeing a lot of teenagers that have had multiple issues, lots of recurrent problems that are coming to us at 16, and that have seen a lot of other health professionals and have never been diagnosed with hypermobility, and that was the pink elephant in the room. So I think just for it to be more well known, I'm trying to get into undergrad training in the pediatric space. Like, I think if we can learn this at uni, that would be amazing, and that would be a better starting point than finding out when you're already a health professional at a course that you're hypermobile. So just more awareness earlier.
Absolutely. I couldn't agree more. And for anyone involved at the universities who might be listening to this, like, hear us. We want to help. We want to be part of the change. So yeah, the earlier we can get the awareness out there, the more we can change that healthcare system in the future. So that's such a beautiful message to leave us with, Katie. Thank you so much for your time today, for being part of this podcast, for being part of the change. Really appreciate it. How can our listeners find you online and in person at Ocean Kids?
Thanks so much, Ashton. It's been awesome. I could talk about it all night, but yeah. So if you want to reach out to us, oceankidshealth.com.au is our practice, or you can find me on LinkedIn as well. But yeah, if you head to our website, you can reach out to us. So we support kids right across Australia, telehealth and in-clinic visits. But yeah, if you've got any questions for me, or if you just want to connect, yeah, I'd love to hear from you. So please reach out. And thank you for listening. I appreciate everyone's time.
Yeah, thank you. Thank you so much, Katie. Thank you for being here. And thank you to all the listeners for tuning in. I love your feedback. So please, if you'd like me to chat with any other guests, please send them through. What topics you want to hear about, what people you want on the show, you let me know and I will track them down. But until next time, we'll catch you then. See?